So, good morning. We're going to continue our discussion of personality disorders. So, cluster A, these are weird type. Think paranoid, schizoid, schizotypal. They have odd and eccentric behavior. The cluster B, wild, antisocial, borderline, histrionic, narcissistic. They have a dramatic and erratic kind of behavior. For cluster C, think of wacky. You're avoidant, obsessive compulsive, and dependent. Characteristic, anxious and fearful behavior. So the paranoid personality disorder, they have a distrust of others, even friends and family. So they are very guarded, they are suspicious, and they struggle to build close relationships. High yield was the hallmark ego defense mechanism, projection, meaning they attribute unacceptable thoughts to others and they often accuse others of being suspicious. Schizoid personality disorder, they choose social isolation. Contrast this one with your avoidant personality disorder, wherein they want to have a close relationship, but they just can't. Why? Fear of embarrassment. So in schizoid, they choose social isolation. They're more comfortable being alone. They do not enjoy close relationships. They have little or no interest in sexual experiences. They have few to no pleasurable activities like hobbies. They lack close friends. They are detached and they have a flat affect. Schizotypal personality disorder. These people, they have odd beliefs or magical thinking. They are superstitious. They believe in numerology. They believe in horoscope. They think they have a sixth sense. They believe in telepathy. Also, high yield ideas of reference. They believe that events and happenings somehow is related to them. For example, in the TV, someone's talking to me in the television, they're telling me something. That's ideas of reference. Or the spike of COVID case is happening. Why? Because I didn't put out the trash last Tuesday. That's the only day that I didn't put out the trash. That's why there's a spike in COVID cases. That's ideas of reference. What's the key feature for schizotypal? Contrast this one with someone in delusions in schizophrenia. So for this schizotypal personality disorder, they're open to challenges to beliefs. They may reconsider their superstition. However, in schizophrenia, even though you challenge them, they will not, right? They will not accept your challenges to their beliefs. Here in schizotypal personality disorder, no hallucinations, no cognitive impairment. Antisocial personality disorder, more common in men. Disregard for rights of others, they often breaks the law. They are impulsive and they lack remorse. So if it's less than 18, you have a conduct disorder. So basically 24% of girls and 40% of boys with conduct disorder go to antisocial personality disorder. So for this disorder, they must be at least age 18 years old and they must have evidence of conduct disorder before 15. So think of this as a progression. So you start with ODD, oppositional defiant disorder. What is this? It means you're against authority figures, home or school. They're against the principal. They're against the teacher. Only with authority figures. That's oppositional defiant disorder. Then they go to another spectrum. We have the conduct disorder. What is this? In the vignette, they're going to say cruelty to animals before the age of 18. So typically 15 and below. Cruelty to animals, like theft, and then they progress. After conduct disorder, when they are more than 18 years old, you can see antisocial personality disorder. Often disregard of right for others, assault, those kinds of behavior. They break the law. For borderline personality disorder, more common in women, they have unstable personal relationship. What's the hallmark ego defense mechanism for borderline? Splitting. My girlfriend is the best girlfriend in the world. My girlfriend is the devil incarnate herself. The world is divided into two sides, the good and the bad. That's splitting. They often have stormy relationships. They have a fear of abandonment. They may accuse others at abandoning them. High yield, the borderline, self-mutilation. So you need to screen for suicide in your patient. Self-mutilation, cutting, burning. They are impulsive. They have spending sprees. They go to Amazon and order all of the products there. They often have sex with strangers, reckless driving. They have suicide gestures or attempts. This relates to their fear of abandonment. You don't care about me, for example, so I'll kill myself. So screen for suicide for borderline personality disorder. High yield, what's the behavioral therapy for this disorder? DBT, dialectical behavioral therapy. This therapy is designed to treat chronic suicidality before. This is, however, now it's a gold standard for borderline personality disorder. What's in DBT? You have mindfulness, you have distress tolerance, and they teach you how to regulate your emotions. It's a weekly therapy for 1 to 2 years. If your patient is suicidal, they're resistant to medication, what are you going to do? Admit the patient and what? We could do? If your patient is suicidal, they come in to the emergency, you admit them, but they are resistant to treatment. They are resistant to SSRI, to SNRIs. What are we going to do? Anyone? Any answer? What are we going to do? They're suicidal. They come in, doc, I have a plan. I'm gonna kill myself today with a gun. What are we going to do? Admit? And then if you give medication, they are resistant. You look in the note, the history, they are resistant to drugs. What's the answer then? Brain simulation? I'm thinking another one.
ECT.
Excellent. ECT. Don't forget that. That's very high yield. As long as they are resistant to medication, you can't do anything, but they are suicidal. You administer ECT. It's very, very safe. Why doesn't it have, why is it controversial? Because of the movie. You remember that movie with Jack Nicholson, Nurse Ratched? One flew over a cuckoo's nest. That's why it's so controversial. ECT is controversial, but it's not. It's very, very safe. Treatment-resistant depression, treatment-resistant bipolar. You can give ECT. It's also safe in pregnancy. Okay. Histrionic personality disorder. They want to be the center of attention. They talk loud. They tell wild stories, and they use hand gestures. They often have inappropriate, sexually provocative behavior. They often wear provocative clothing. They touch others frequently. They are very concerned with physical appearance. So you can see them in exotic outfits. They have exotic shoes. They have exotic hats. Narcissistic personality disorder. They have an inflated sense of self. They brag. They think everything they do is great. They lack empathy for others. So they think other people are competitors. They want to hear they are great. They overreact to criticism with anger and rage. Avoidant personality disorder. Again, they avoid social interactions. Why? They feel inadequate. They want to have a relationship, a stable relationship, but they just can't because they're afraid people won't like them. They are afraid of embarrassment, right? Maybe my crush won't like me. Right? This is different from schizoid. Remember, the avoidant personality disorder, they want to socialize but can't. Schizoid, they prefer to be alone. They are aloof. Okay? Please make sure to know the contrast between the two of them. Now, dependent personality disorder, they're clingy. They have low self-confidence. They struggle to care for themselves. They depend on others excessively. Right? They are rarely alone. They always want to have a relationship. They are hard to make decisions on their own. They want someone to tell them what to do. They have difficulty expressing their own opinion. And sadly, they may be involved in abusive relationship. They just can't get away. Okay? They're dependent. They're clingy. OCPD, obsessive compulsive personality disorder. They are preoccupied with order and control. They love to do lists. They always needs a plan. Is OCPD ego syntonic or ego dystonic? Is OCPD ego syntonic or ego dystonic? Anyone? What are we thinking?
Can
Go
you
ahead.
repeat the choices again?
OCPD, ego syntonic or ego dystonic?
Ego dystonic?
I'm careful, it's OCPD, not OCD. OCD, remember you from yesterday? I talked about this one, I differentiated them. So, OCD is ego dystonic. The behavior doesn't comply with the goal. For example, the goal is to get out of the house. In OCD, you can't get out of the house. You keep on doing the compulsion. You keep on cleaning, checking the stove. You keep on cleaning the house, right? In OCPD, it's ego syntonic, meaning the behavior is congruent to the goal. For example, the goal is going shopping. If you have OCPD, you make lists and then you get out of the house and go shopping. Okay, that's the difference. OCPD, ego syntonic. OCD, disorder, it's ego dystonic. That's high yield. Again, now we're moving on to dissociative disorders. So dissociative amnesia or psychogenic amnesia, inability to recall autobiographical memories. You ask them, so what's your job? I don't know. Where do you live? I don't know. Why are you here in the emergency room? I don't know. It usually follows major trauma or stress. It is reversible, right? And the patient is not bothered by the lack of memory. Remember, the amnesia is not explained by another cause, okay? Dissociative amnesia, inability to recall autobiographical memories. They don't know their own story. This is different from other forms of amnesia. You have large group of memories, right? Caused by overwhelming stress. This is also different from repression because it's a loss of autobiographical information. You don't know your name, you don't know your job, you don't know your home address. Example of this is a woman is attacked in an elevator. And then you conduct an interview with this woman and she does not recall her job or where she lives, any autobiographical info. Okay? This is usually self-limited. What's the treatment? CBT, psychotherapy. Dissociative fugue. This is a subtype of dissociative amnesia. Fugue is Latin for flight or flee. Sudden travel or wandering in dissociated state. Example, a manager fired from work goes missing and you found the manager in another town, but the manager has no recollection of the prior job. So this is dissociative fugue, sudden travel or wandering in dissociated state. An extreme of depersonalization and derealization is DDD, right? What do you mean by depersonalization? Meaning you feel like your body is detached. You are estranged from your own self. You feel like you're in a dream. You feel like you are watching yourself from above. So you have loss of control over thoughts and actions. Derealization is you feel detached from your surrounding world. So you can see your room, they seem unreal. They're foggy. You can see visual distortions. Know the difference between the two? It's high yield. DDD is often triggered by trauma. must cause significant distress or impairment. However, high yield, intact reality testing for DDD. The patient is aware that the sensations are not real. I am not up there. I am here. I am in this room. Right? I know that I am in this room. Contrast that with psychosis, where you don't have any intact reality testing. That's high yield. What's the treatment for DDD? CBT or psychotherapy. Again, depersonalization, derealization disorder. Know the meaning of depersonalization and derealization. Know for this disorder, you have an intact reality testing. The patient is aware that the sensations are not real. I'm not having hallucinations. Okay, I know that I am here. I'm not up there. Contrast that with psychosis, they don't know. Okay, good. Next, dissociative identity disorder. In DSM-4, this is commonly called a multiple personality disorder, but they phase the term out. It's more common in women. Yield associated with abuse, childhood trauma, sexual, physical, verbal abuse, especially sexual abuse, often before age 6. They develop this multiple identities, right? They have 2 or more distinct identities. They have personality states. They have alterations in their behavior, memory, thinking. And before they switch into different personalities, they have gaps in memory about events. The symptoms causes distress or problems in functioning. What's the treatment? CBT or psychotherapy. Somatic symptom disorders. Somatic symptoms, they cause distress. This characterizes persistent thoughts about seriousness of symptoms. You have anxiety about the symptoms. You have excessive time and energy devoted to the symptoms. And it is persistent, right? Usually more than 6 months. Conversion disorder, commonly known as functional neurologic symptom disorder. So you have a sudden onset following a stressor. So you have a neurologic symptom. For example, inability to speak or move, blindness, seizures. You do a neurologic workup, but it is normal, right? Example, the absence of plantar flexion, but can stand on toes. Example of this is, while at work, you saw someone die at work, right? So the patient is dying. And then suddenly, when you get off work, you can't see, you're blinded. You go to the doctor, and then the doctor check your eyes, ophthalmology consult, and everything is fine, right? Cranial nerve number 2 is fine. They did everything. Oculomotor, cranial nerve 3, it's good. There's nothing, right? But you have that neurologic symptom. Okay, that's conversion disorder. The presence of a neurologic symptoms in the absence of normal neurologic workup. So high yield for the patients that have conversion disorder is label indifference, which is the patient shows lack of concern about the symptoms. Okay. They have a symptom, neurologic workup normal, and when we talk to them about the symptoms, they don't care. They're indifferent to the symptom. We call that label indifference. That's high yield. Illness, anxiety disorder. They have a preoccupation with having undiagnosed illness. They don't have any symptom, no somatic symptoms at all, right? But they are preoccupied with having undiagnosed illness. You have anxiety about health, excessive health-related behaviors, and this should be present for at least 6 months. Factitious disorder on self, Munchausen syndrome. They have a falsified medical or psychiatric symptoms done consciously. Why? Out of desire for attention. These people, factitious disorder on self, they want to be in a sick role, high yield, okay? They want to be in a sick role. They're comfortable to be a sick person. The patient may feign illness, they may aggravate genuine illness, and the patient is often willing to go for tests and surgeries. Where can we see commonly factitious disorder on self? Healthcare professionals, doctors, nurses commonly have this kind of disorder. They want to be in the sick role. They're comfortable to be a sick person. They're falsely injecting themselves insulin to have a low blood sugar just to become sick. Okay. This is done for one, primary internal gain from illness. As I've said, the patient feels better in sick role. The sick role solves some internal conflict that they have. For example, patient is afraid of work or afraid to be alone. So it's chronic, persistent. What's the risk factors? What are the risk factors here? Female gender, unmarried, and as I've said before, prior or current healthcare worker. Look for that in the vignette. Now, contrast that one with this, Munchausen by proxy, or factitious disorder on another. So this is often a parent of a child or caretaker of the elderly. So factitious disorder on self, comfortable in the sick role. I want to be in the sick role. Factitious disorder on another, I want to be a provider. Okay, that's the difference. They want to be a caregiver. They want to take care of someone in order to resolve that internal conflict. Now, malingering is a consciously falsified medical symptoms. This is done for what? Secondary gain, external gain. Example, it allows patients to miss work. Why? Workers' comp, right? I'm going to get paid. This is self-limited, and it usually ends when secondary gain is achieved. Don't forget, malingering is not a DSM-5 psychiatric disorder. So the factitious disorders, internal gain, primary gain for yourself. Malingering, secondary gain, external gain. Now let's talk about eating disorders. Anorexia nervosa. So diet and exercise that leads to low body weight, high yield. Look for BMI. If the BMI is less than 18.5, it's almost always anorexia nervosa. Why? Intense fear of gaining weight. They have a distorted perception of body weight. Increased mortality from malnutrition. There's two subtypes. They can be restricting. They have low calorie intake and they go to the gym for 5 hours. Okay. Another subtype is binge purging. After eating, they go to the bathroom and purge, right? Don't forget Russell sign and their knuckles. So what are the effects of anorexia nervosa? High yield. Decreased GnRH secretion. If you have a decreased GnRH secretion, what happens? Decreased LH and FSH. You can have functional hypothalamic amenorrhea, thyroid, low T3, right? But you have a normal or low TSH or T4. We call this one a sick euthyroid pattern of thyroid function tests. Another one, hyponatremia. They have low solute intake. Why? Normally, anorexics, they have a tea and toast diet. You cannot get enough calories from there, right? And also, creatinine is low. Why? Because of muscle mass. Remember, on your second exam, our body tries to preserve muscles, right? Remember the alanine cycle for your muscles? They try to preserve muscles. First, they need to get glycogen. After 24 hours is gone, then you can have ketones for your body. Then the last resort is to break down muscles. For anorexics, you can expect to see a low muscle mass. So the creatinine is low. And if it's the purging type, expect hypokalemia. Question. What happens to the T wave in hypokalemia? Increase or decrease? Increase or decrease? Hypokalemia. What happens to the T wave?
Decrease.
Decrease. Of course. Yes, excellent. So if it's increased T wave, it's hyperkalemia. Or there's a U wave. Remember from term 1, if there is a U wave, after the T wave, there's a U wave, think hypokalemia also. What happens to the bone? Decrease in bone density. Remember, estrogen is protective. Once you're menopause, then you don't have any estrogen, right? So you're prone to decrease in bone density. You also have high cortisol. Why? Stress. The body thinks that you're in a lot of stress. That's why you're producing cortisol. Remember, cortisol, it's a stress hormone. So for anorexics, osteopenia, you're going to also have osteoporosis. Let's look at hematology, bone marrow suppression. You can have anemia, you can have leukopenia, you can have thrombocytopenia, so decrease in platelets, decrease in WBCs, and decrease in RBCs. You can also have a decrease in reticulocytes due to bone marrow suppression. What happens to the heart? Decreased cardiac mass. So it may lead to cardiomyopathy. We're going to learn more about the different kinds of cardiomyopathy in term 4. It can also cause arrhythmias. You're going to learn more about arrhythmias in term 4. In the physical exam, as I've said, and in the vignette, you should have low BMI. If it's less than 18.5, think anorexia nervosa. Okay? Always check the BMI. To contrast anorexia nervosa with bulimia nervosa. Bulimic patients, they have normal BMI. Anorexic patients, they have a low BMI. That's the differentiating factor in the vignette. Okay? What can we see aside from the low BMI in the physical exam? They're going to put in the vignette bradycardia, hypotension, decreased bowel sounds, hair loss, or they're going to describe this soft, fine hair, lanugo, commonly seen in babies, right? What's the treatment then? A patient comes in, anorexic, I refuse to eat. Future doctors, what are we going to do? First, nutritional rehabilitation. You admit them to the hospital and you observe them eat their food, basically. You observe them, right? And then psychotherapy. CBT, again, your favorite. Or we could do olanzapine. Why are we giving olanzapine, an antipsychotic? A second generation antipsychotic in someone who's anorexic. Do they have psychosis? Do they have psychosis? Why are we giving them olanzapine, an antipsychotic? Anyone?
Maybe to treat their delusion.
Okay, in anorexia, there's no psychosis. Think of the side effect of your second generation antipsychotics. What's the main side effect? Weight gain. So we are giving olanzapine. Why? Because of the side effect. All of your second generation or your atypical antipsychotics, for example, olanzapine, clozapine, aripiprazole, all of those, the major side effect is weight gain. So you can have a metabolic syndrome. You can have hyperlipidemia. You can have weight gain. So we're giving olanzapine. Why? Because of the side effect, which is weight gain, to increase their weight. Not because they are psychotic, but because of the side effect, right? So if we're going to hospitalize them, why are we going to hospitalize them? What are the reasons? First, very low body weight. If the BMI is less than 15, if it's 12 or 11, admit inpatient. Hemodynamic instability. They have bone marrow suppression, aplastic anemia, admit inpatient. They're dehydrated. You check the sodium and potassium. Hypokalemia, hyponatremia. You admit them inpatient. They refuse to eat. They tell you, I refuse to eat. Admit them, inpatient. Those are your hospitalization indications. High yield. So if you're giving them nutrition, right, what happens? Be careful. Why? Refeeding syndrome. You have hypophosphatemia. Remember, they already have low phosphate from poor nutrition. If you give glucose, what happens to the insulin level? Increase. What happens to metabolism? Insulin is anabolic. All anabolic reactions in the body will be increased. So you further deplete the phosphate from cellular uptake, meaning there's a loss of ATP. So what if I lost my ATP? ATP is essential for your heart and your lungs to function. You can have cardiac and respiratory failure. High yield, check for refeeding syndrome. What's the hallmark? Check the phosphate, hypophosphatemia. Most common fatality in anorexics is cardiac. So you have poor contractility, low stroke volume. You can have heart failure. Question from term 1, what's the difference between left-sided heart failure and right-sided heart failure? Which one has anasarca? Which one has anasarca or generalized edema? So we need to build our knowledge, okay? We have a BSc coming up, Which one has anasarca? Generalized edema, right-sided, left-sided?
Go with right-sided.
Right-sided, excellent. Left-sided heart failure is what? Pulmonary edema, right? Good. You can have arrhythmias also. So how are we going to prevent refeeding syndrome? Slow refeeding. Always check the phosphate levels, okay? So gentle increase in caloric intake. Now, bulimia nervosa, binge eating. In the vignette, you can see inappropriate compensation to avoid weight gain. So they vomit, they use laxatives, right? They use diuretics, Lasix, hydrochlorothiazide, enemas, excessive exercise, fasting, and they have severely restrictive diets. How are we going to contrast bulimia nervosa from anorexia nervosa? Look at the BMI. If the BMI is normal, it's bulimia. If it's below 18.5, it's anorexia. Bulimia commonly coexists with other disorders, anxiety, depression, PTSD, and substance use. Look for the labs also. Increased bicarb. Why? If they're on the purging type, they vomit, right? You can have contraction, alkalosis. Alkalosis, what happens to pH? In alkalosis, increase or decrease? In alkalosis, what happens to the pH level? Decrease or increase?
It's gonna
Excellent.
increase.
Excellent, Lexi. So it is increase, right? You can put your answers in the chat box, right? So vomiting, alkalosis, you have an increase in pH. What happens to the bicarbonate level to compensate? Increase also. Check the potassium level always. In bulimia nervosa, you have hypokalemia, loss of potassium. Remember, potassium is very important. Why? Because of the muscle contraction in the heart also. Check for urinary chloride. It is usually low and have hypochloremia. This image here on the right, you can see here sodium, KClCO2, BUN, creatinine, and glucose here. So this is when you go to your rotations, specifically IM. This is very essential. You can see this one. It's like a fishbone chart, right? What else can you see in bulimics? In the vignette, they're gonna say parotid gland hypertrophy. There's a swelling in the parotid gland. What cranial nerve goes on top of the parotid gland?
7.
Excellent! Cranial nerve 7. Good job. So you can also have sialadenosis. It's just a fancy saying. It's a fancy term for parotid swelling, okay? And in the vignette, we're gonna say tooth decay, right? Why? Because of erosion of dental enamel, because you're purging. Again, in the vignette, they're not gonna say Russell's sign. They're gonna say there are scars on the knuckles. You look at the knuckles and you see there are scars. So this is called the Russell's sign. Why? Why do we have Russell's sign? This is from induced vomiting, right? They use their knuckles to vomit. What's the treatment again? Nutritional rehabilitation. What else? CBT, psychotherapy. What else? SSRIs. Examples of SSRIs: fluoxetine, paroxetine, escitalopram, citalopram, and sertraline. Common side effect for SSRIs? What's the most common side effect? What's the most common side effect for SSRIs? Someone is typing. Headache, GI issues, excellent. The main thing for SSRIs is sexual dysfunction. So they have decrease in libido. That's the most common. Excellent, Carrie. Sexual dysfunction. Yep. SNRIs. What's the most common? SNRIs. Your venlafaxine, your duloxetine. What's the most common side effect that you can see? Hypertension. Increase in blood pressure. That's the most common. Excellent, Lexi. So let's go. Let's see here. What's next? Binge eating disorder. What is binge eating? So compulsive overeating. They have excessive, large amounts of food. They eat it quickly. And then they feel shamed and embarrassed. Okay? However, there is no compensation. They don't use laxatives. They don't use diuretics. They don't over-exercise. Okay? They just keep on eating. Compulsive overeating. Think about that. Okay? What's the side effect? If you keep on eating, you're going to get fat, right? So you're going to have weight gain. So this occurs at least once a week for 3 months. Compulsive overeating, at least once a week for 3 months. So comorbidities for BED, anxiety, depression. Of course, you have a high risk of type 2 diabetes. What's the treatment? Again, CBT, always psychotherapy. And you can use SSRIs. Okay, I don't know if you know this one. A drug for ADHD. You can also use in binge eating disorder. Does anyone know? Your ADHD drugs, or methylphenidate, lisdexamfetamine. You can also use that in binge eating disorder. Why? What's the side effect of those drugs? Excellent, Carrie. So lack of appetite. You're gonna lose the weight, right? What's the mechanism of action of methylphenidate? Is it acetylcholine or norepinephrine? Reuptake. For ADHD. Norepinephrine. Excellent. It is about norepinephrine. Good job, Carrie. Another drug is topiramate, Topamax, one of your anticonvulsants. So they block sodium channel. Why? It's beneficial because the side effect, the most common side effect of topiramate is weight loss. Okay, so you could use lisdexamfetamine or methylphenidate, your ADHD drug. You could also use anticonvulsant, your topiramate. Side effect, weight loss. There you go. Both lead to reduced weight. Now, let's go to substance use disorder. Two or more of the following during 12-month period. Tolerance, withdrawal, taken larger amounts. You can see all of those. Just read them in your free time. High yield, stages of change. They love this. Pre-contemplation, contemplation, preparation, action, maintenance, and relapse. Pre-contemplation. I don't have any problem, doc. I'm good. I'm just drinking socially. No intention of behavior change. The patient does not recognize or acknowledge the problem. Contemplation. I know, doc, that I'm drinking too much, but right now I don't want to change. They are aware of the problems existing, but they are not yet willing to change. Preparation. Doc, I'm worried that I'm drinking a lot. I want to go to rehab. They are intending to take action. Action, they are in rehab up until maintenance. Maintenance, they go to AA or NA meeting they haven't sponsored, right? And sometimes they relapse. After relapse, you go back again. Okay, this is high yield stages of change. Alcohol, ethyl alcohol, ethanol. Tell me the metabolism of alcohol, please. Who can tell me? You can put it in the chat. From ethanol to acetate, acetaldehyde, acetaldehyde to acetate. Who can tell me the enzymes that we're going to use? Of course, they're all dehydrogenases, right? We just remove OH. You can type in the chat. So from ethanol, alcohol to acetaldehyde, acetaldehyde to acetate. Amanda's typing. You can type in the chat if you don't want to talk. This is a safe space for answers, okay? So you have alcohol dehydrogenase and acetaldehyde dehydrogenase, right? So if for alcohol dehydrogenase, give me a drug that inhibits it. Fomepizole, remember your fomepizole for poisoning, methanol or ethanol poisoning. How about what inhibits acetaldehyde dehydrogenase? Excellent, Lexi. Disulfiram or your antabuse, which is not commonly prescribed today because of the side effects. So alcohol metabolites with the liver. It activates GABA receptors. Remember the effect of GABA? For calm down, for sedation. How? Open the channel. GABA channels are open. Chloride goes inside the cell. What happens to the action potential? You hyperpolarize the cell. You are increasing the duration of refractory period. The absolute refractory period is increased. What happens to the action potential? It's decreased. Okay? Just a recap from term 1. So if you're intoxicated from alcohol, what can you see? It's a CNS depressant. Slurred speech, incoordination, unsteady gait, stupor, and coma. What are the biomarkers? Check the liver. Check for liver damage. Check for GGT, right? And check for AST versus ALT. Question, in alcohol, which is between your AST and ALT, which is much more increased? Is it AST or ALT? Excellent, Lexi. So it's AST. How about hepatitis or infection? Which one is increased, AST or ALT? Excellent, Tolu. So it's ALT. Okay. Think about liver infection, right? L, liver. If you have a hepatitis, think ALT. For alcohol, AST is much more increased. And then they're going to put in the vignette GGT is also increased. All right. So check your liver markers. Alcohol poisoning. If you have a very high blood alcohol level, what happens? Respiratory depression. Remember, your GABA receptors, right? You're prolonging the absolute refractory period. You are decreasing the action potential. So it can lead to respiratory depression. It can be fatal. It may require you to go to ICU. Alcohol withdrawal. So heavy drinker comes in. He's been in the hospital for a couple of days, right? And he's withdrawing. Signs and symptoms. Tremors, the first thing that you can see. Tremors. Anxiety, GI upset, headache, sweating, palpitations. This is deadly. Why? Because it can induce seizures. 24 to 48 hours after last drink, you can have a generalized tonic-clonic seizures, single or in clusters of 2 to 3. You can also see visual hallucinations. 24 to 48 hours after last drink. They see insects or animals. They hear voices, right? So you have visual hallucinations, you have tremors. 24 to 48 hours after the last drink. The worst thing is this. After 48 to 96 hours after last drink, and you didn't treat, you saw the tremors, right? You saw the visual hallucinations, and you didn't give the patient anything. Now he's on delirium tremens. So DTs, this is the most severe of the withdrawal manifestations. 20% mortality, guys, in some studies. So what is DT? They now have delirium. They are now agitated, fever. They are drenched in sweat. They feel like they're dying. This is horrible, guys. You have autonomic hyperactivity, tachycardia, and hypertension. They are going to die, definitely, from hyperthermia, cardiovascular collapse, arrhythmias, and fluid and electrolyte abnormalities. So what are we going to give? Alcohol withdrawal, benzodiazepines, right? Question, what's the mechanism of action of benzodiazepine? You can say it out loud or you can put your answer in the chat. What's the mechanism of action of your benzodiazepines? GABA, excellent. Oops, is that how you pronounce your name? Sorry. So GABA receptor, right? Excellent, Amanda. Something with GABA. So the benzodiazepines, there's a decoy. They're decoy for your GABA A receptors. Competitive, right? So they attach to the GABA receptors to increase the frequency of opening, right? Contrast this one with your barbiturates, okay? Barbiturates is they prolong the duration of the opening of the GABA channel. Your benzodiazepines, they increase the frequency of the opening of the GABA channels. The GABA channels open, chloride will go inside the cell, hyperpolarized, increase absolute refractory period, decrease action potential. So you give diazepam or chlordiazepoxide. However, high yield. Give me the 3 benzos that you give. If your patient has cirrhosis or liver failure, you cannot give diazepam. That's a wrong answer. You cannot give chlordiazepoxide. That's wrong. So what are we going to give? There are 3 drugs that we're going to give. LOT, lorazepam, oxazepam, temazepam. Okay, LOT or OTL, outside the liver. That's how we remember it. So those 3 are safe in patients who have cirrhosis or something wrong with the liver. Okay, you can give those 3. All right. So if you give benzos, it improves the agitation and it prevents the progression to DTs. Alcohol use disorder, recurrent drinking causing impaired social functioning. So what if I keep on drinking? What will happen to me? You can have a lot of problems. Gastritis, hepatitis, cirrhosis, pancreatitis. Look at the MRI on the lower right side. See the pancreas there? You can see the calcifications. Look here, right? You can see the calcifications. What happens to the cardiac? Oh, dilated cardiomyopathy. You can have hypertension. What else? Malignancy. Remember, esophageal cancer. You can have a Plummer-Vinson syndrome, right? Which can lead to Boerhaave syndrome. More of this in term 4. And you can have oropharyngeal cancers. I think the high yield here is the pancreatitis. You can see the calcifications here. Your pancreas, look at that. It's beautiful. Another deadly complication of alcohol use disorder is Wernicke-Korsakoff. Wernicke's, acute encephalopathy. Question, reversible or irreversible? Wernicke's encephalopathy, reversible or irreversible? Careful. We need to be careful. Wernicke's. This is reversible. Wernicke's is reversible. Excellent, Amanda. So it is reversible, right? Acute encephalopathy. Wernicke's area in the brain. Tell me, where can we find the Wernicke's area in the brain? Where? Neuroanatomy. Can someone tell me, where is the Wernicke's area? Wernicke's area. Where is it? In the brain. Where is it?
Left hemisphere?
No, the specific part. Temporal lobe, yes. What gyrus? Superior temporal gyrus, right? The Broca's area is where? Inferior frontal gyrus, in the frontal lobe, right? So please, neuroanatomy, it's a wonderful subject, right? Integrate, okay? Don't forget the Brodmann's number. That SGU loves the Brodmann areas, but it's not used anymore in neurology. So Wernicke's, again, this is reversible, acute encephalopathy. However, Korsakoff, irreversible. You have a chronic neurologic condition now. Why? What happened? B1 deficiency, right? Due to alcohol use. What happens to the mammillary bodies? Atrophy, high yield. You can see atrophy of mammillary bodies. So what if I damage my mammillary bodies? What happens, guys? Tell me. What's the function of the mammillary bodies? It is for You can type in mammillary bodies. Always associate this one with confabulation. Excellent, Lexi. This is memory, right? Memory. Think about confabulation. Anterograde. Why do they confabulate? Because they have anterograde amnesia. They don't know. They make up their past because of this atrophy of your mammillary bodies. Also associated with damage of thalamic nuclei. So what if I damage my thalamus? If I damage my thalamus, what happens? Think about movement. Think about ataxic gait for alcoholics. Balance. Remember? Excellent, Amanda. Sensory relay station is in your thalamus. Good job. So, Wernicke's encephalopathy. High yield, triad. 3 symptoms. 1, nystagmus. 2, ataxia. 3, confusion. Okay? That's high yield. Often reversible, as I've said. Just give B1, thiamine. Korsakoff amnesia. So recent memory is affected. They can't form new memories. They confabulate. You have confabulation. You already damaged the mammillary bodies. You can't remember anything, so you make things up, right? You have lack of interest or concern, apathy, and this is permanent because you already damaged an important organ in your brain, right? A part of your brain. So alcoholics, they have nutritional deficiencies. B1, thiamine. What kind of reactions use B1 in the body? Where do you use thiamine? Dehydrogenases. Excellent, Amanda. B6. What kind of reactions use B6? Carboxylation or decarboxylation? You can type in. Or you can just shout it out. B6. Redoxing. Decarboxylation for your B6. B7 is your carboxylation. How about folate? B9. Why is folate important? Why is folate important? B9. What is it used for in the body? What reactions? You're right. If you don't have folate, Lexi, you can have neural tube defects, right? What happens to ALP in your neural tube defects? Increase or decrease? Alpha fetoprotein, increase or decrease? Increase. Excellent, Amanda. So you can also have magnesium deficiency or calcium deficiency and phosphorus deficiency. How are we regulating calcium in the body? How? What hormone regulates calcium in the body? PTH. How does it affect calcium levels? Where? From bone to serum. So basically, if you have PTH acts on your nephron, right? To convert calcidiol to calcitriol. So you increase 1-alpha hydroxylase to increase the conversion of those 2 products, okay? What else? So if you see an alcoholic in the emergency department, you usually have this yellow thing here on the right. This is a banana bag. So you have IV infusion to alcohol users. It's yellow. Why? It's a combination of thiamine, folate, and magnesium, right? Don't forget, give thiamine first before giving glucose, okay? Always give thiamine first before giving glucose in an alcoholic patient. That's high yield. Why? Thiamine first because thiamine is a cofactor for your glucose metabolism. If you give glucose first, it will worsen the thiamine deficiency. So high yield, give thiamine first before giving glucose. What's the treatment? AA. We're going to have a sponsor. Drugs, FDA-approved drugs to reduce the risk of relapse. Disulfiram or antabuse inhibits acetaldehyde dehydrogenase. You could do naltrexone. What is naltrexone? What's the mechanism of action of naltrexone? Mu-opioid agonist for your naltrexone and acamprosate. Most common side effect of acamprosate. What's the most common side effect of acamprosate? GI. Think of diarrhea. Okay? Now, cocaine intoxication. If someone is taking cocaine, you have increased energy, you have decreased need for sleep, they're alert, they're euphoric. Hallucinations. Classically tactile. In the vignette, they're going to say, oh, bugs. The patient says, bugs are crawling on my skin. They have paranoia, fever, think autonomic hyperreactivity, anxiety. What's the treatment? Benzodiazepines. Dilated pupils, high yield for cocaine intoxication. Autonomic hyperreactivity, tachycardia, hypertension. Sympathetic nervous system activation, the stimulation of your alpha and your beta receptors. Cocaine intoxication mimics MI. Okay, so you need to rule out MI. Treatment, benzo, again, sedating, calming. You can give aspirin, right? And you need to avoid beta blockers. Why are we going to avoid beta blockers in someone who has cocaine intoxication? What's the mechanism of action of cocaine? Inhibits reuptake of what? Acetylcholine or norepinephrine from term 1? Anyone? Mechanism of action of cocaine. Inhibits reuptake of, is it acetylcholine or norepinephrine? It's not acetylcholine, it's norepinephrine. Okay. Why are we going to avoid beta blockers? Increase alpha effect. Okay. Don't give beta blockers if someone has cocaine intoxication. Why? Because you are worsening the hypertension. You already have autonomic hyperreactivity. Okay. If you give beta blocker, beta 1, beta 2 is out, but you have unopposed alpha activation. Alpha 1 and alpha 2 is still activated. So you're worsening the hypertension and the chest pain. So you need to avoid beta blockers. How about cocaine withdrawal? So it's not life-threatening. So cocaine, it's an upper drug, right? For intoxication, everything is up. For withdrawal, think the opposite. Everything is down. Okay, so you're depressed, you're anhedonic, you can have cravings. Amphetamine intoxication, it's an upper, similar to cocaine. You have euphoria, you have sympathetic stimulation, tachycardia, hypertension, pupillary dilation. What's the treatment? Just like in cocaine intoxication, it's benzodiazepines. How about for withdrawal symptoms? Same thing as cocaine, downer. Right. Heroin, usually injected into the vein, high yield, Most common side effect of heroin abuse is bacteremia. You can have the tricuspid endocarditis. Where can we find the tricuspid valve? Where can we find this? You can put your answer in the chat or you can just jump in. Where can we find the tricuspid valve? Of course, it's in the heart, but is it in between the left atrium and left ventricle or right atrium and right ventricle? Thank you so much, Amber. So it's in your between your right atrium and right ventricle. One of the side effects of lithium, if you give lithium to someone who's bipolar, is Ebstein's anomaly. Let's go back to term one. What do you mean by Ebstein's anomaly? What do you mean? Ebstein's anomaly. What does it mean? You can just jump in and tell me or in the chat. So Lexi has a great idea. So the tricuspid valve is displaced into the right ventricle. Okay, good. That's good. So what if the tricuspid valve is displaced into the right ventricle? What happens then? Think what will happen. You have a valve that's being displaced into the right ventricle. What happens to the right ventricle? It becomes atrialized. It becomes like an atria. Now, as a consequence of that, what happens? A lot of typing. Good job. Okay, I'm thinking about heart failure. So it predisposes you to have right ventricular heart failure. So that's Ebstein anomaly. Good job. So we're doing BSc review and we're doing NB3 exam review at the same time. Hepatitis B and C. What zone of the liver is affected in hepatitis B and C? Infection. What zone of the liver? Okay. What is it? Are you sure about that, people? Are you sure it's zone 3? Zone 1 is, okay. Zone 1 is right. You're right. It's zone 1. This is a periportal zone. It is affected first in viral hepatitis, or for example, if you ingest acetaminophen overdose. Zone 1, right? Toxic substance ingestion. For zone 2, the only thing that I can remember is yellow fever for zone 2. That's it. For zone 3, the only thing that I can remember is cytochrome P450, right? Okay, good job. And HIV, you're gonna learn HIV in term 4. So what can you see in a patient who is intoxicated with opioids? Slurred speech. The most deadly side effect is respiratory depression. Cough suppression also. And in the vignette, meiosis, small pupils, except for meperidine. Another side effects, constipation, nausea, vomiting, skin warmth, and flushing. High yield opioids are very addictive, and tolerance develops except to meiosis and constipation. That's high yield. What do I mean by tolerance? Tolerance means less effect of drugs over time. You need higher doses required to achieve effect. Again, high yield, no tolerance to meiosis and constipation. Opioid intoxication, most common cause of drug overdose death in the States. Decreased respiratory rate, decreased bowel sound, you have meiotic constricted pupils. Sometimes you can have seizures, most commonly if you overdose on tramadol or meperidine. What's the treatment? Narcan, naloxone. Look here. Look at the chemical structure of naloxone. Looks like morphine, right? It's a short-acting opioid antagonist. However, it may cause withdrawal if dose is too high. If you give a dose of Narcan, if it still doesn't work, give another dose. If it still doesn't work, give another dose of Narcan. Okay? Why? It's a competitive antagonist of morphine. So the patient is in the hospital. The patient has been using opioid. It's been a couple of days. Now he's withdrawing. What can we see? High yield. Yawning. Rhinorrhea, lacrimation. Pillow. Erection. Right? The hairs on your skin is up. That's pillow erection. You can have nausea, vomiting, abdominal cramps. You can have diarrhea. It starts 6 to 12 hours after the last dose. Restlessness. You have reversal of CNS, eye, skin, and GI effects. But I want you to focus on the three. In the vignette, we're going to say yawning. The patient is always yawning. Rhinorrhea, like, and lacrimation, and pillow erection. What's the treatment? You need to minimize withdrawal symptoms. You can give opioid agonists like buprenorphine, a partial agonist, or methadone, or you can give clonidine. Why are we giving clonidine? It's a central alpha agonist. It blunts sympathetic activation, right? It also has a sedating effect. Barbiturates, your phenobarbital or pentobarbital. These are anti-seizure drugs. They activate GABA. They used as sedatives in the past. Now we're not going to use this anymore. Why? We have benzodiazepines. Similar effects to alcohol. Think CNS depressants. This is dangerous. Why? Because if you drink alcohol and you're taking barbiturates, you're going to die. I think that's what the cause of death of Marilyn Monroe. It's overdose of barbiturates, and she's taking alcohol. Right. So that's why her picture is there. The quintessential woman, Marilyn Monroe. So if you have overdose of barbiturates, what happens? Respiratory depression. There is no antidote, people. In respiratory depression, you cannot reverse it. You need to be put on a respirator. Okay? So supportive care. Heavy users must be weaned from barbiturates. Because if you withdraw the drug completely, they can have delirium, hallucinations, and seizures. And death, of course. They can have cardiovascular collapse. Benzodiazepines here, diazepam, oxazepam, lorazepam. Many medical uses, seizures, anxiety, alcohol withdrawal. What's the mechanism of action? GABA agonist, increased GABA activity. It rarely causes respiratory depression. Classic overdose presentation, CNS depression with normal vital signs, altered mental status, slurred speech, and ataxia. But in the vignette, check the vital signs if they're normal, but they have CNS depression. And then it is benzodiazepines. They all end in PAM. Diazepam, oxazepam, lorazepam. Those are your benzos. So what are we going to give? Benzo overdose, flumazenil, high yield. This is antagonist of your benzodiazepine receptors. However, this is very controversial. Why? Because it induces seizures. Okay? It induces seizures. It may cause withdrawal seizures. But for your exam, benzo overdose, you give flumazenil, cocaine, intoxication, cocaine intoxication, you give benzodiazepines. If someone is withdrawing from benzos, what can you see? Tremors, that's the first thing that you can see. Anxiety, you can have dysphoria. Hypersensitivity to sensations. In the vignette, they can say Why is it too loud? Someone is loud in the room, right? Or when you touch them, they feel it. They're very sensitive to touch. They can also have some psychosis. They can have hallucinations, visual, tactile hallucinations. They can have seizures. Right? For benzodiazepine withdrawal, that's the treatment. You give them benzos. Marijuana, yep. Your 420, sticky icky, derives from cannabis or plant. What's in there? Tetrahydrocannabinol, also called dronabinol. And this THC, it stimulates the cannabinoid receptor. So the cannabinoid receptor is for pleasure reward system in the brain. That's why when you activate the receptor, right, you feel there's a reward, you feel pleasure. Signs and symptoms of someone who's intoxicated with marijuana, they love this. Conjunctival injection, that's high yield. This is conjunctival injection. They're gonna put it in the vignette. Other things, euphoria, anxiety, dry mouth, increased appetite, tachycardia, blood pressure fluctuations, but no hallucinations or psychosis. Next, ecstasy or MDMA. It has a major effect on serotonin. Serotonin is synthesized from what amino acid? Serotonin is synthesized from what amino acid? Anyone? Excellent. Tryptophan. Good job, Amanda. So, if you're taking ecstasy, you're increasing the levels of serotonin. Remember, serotonin also is for feeling good about yourself. Again, pleasure, you feel rewarded. Okay, that's the effect of your serotonin. High yield, signs and symptoms of someone who's intoxicated. Bruxism, the grinding of the teeth. Increased sexual desire, increased sociability, alertness, and euphoria. But definitely bruxism. Again, autonomic hyperreactivity, tachycardia, hypertension, hyperthermia, hyponatremia, you're very active, your body is overactive. So you need to increase the fluid intake, right? They commonly die with seizures if you have excess intoxication. It is also hepatotoxic. Check for right upper quadrant pain and check for AST and ALT level. And it can cause serotonin syndrome. Question, what's the difference between serotonin syndrome and neuroleptic malignant syndrome? They both have autonomic hyperreactivity. They have hyperthermia. They have tachycardia. They have hypertension. But how are we going to differentiate between the two? Between serotonin syndrome and neuroleptic malignant syndrome. Anyone from the chat, or you can just jump in. Serotonin syndrome most commonly seen in SSRIs, SNRIs, MAO inhibitors, and tricyclics. Neuroleptic malignant syndrome most commonly seen in antipsychotics, your typical antipsychotics, your fluphenazine and your Haldol. Now tell me the differentiating factor in the vignette, because they both have autonomic hyperreactivity. So how can you decide which is which? Anyone? What's the differentiating factor between the two? This is psychotic. NMS would happen within 1 to 2. I'm asking in terms of the lab results. What can we see? Think about muscles. Think about muscles. What happens? So in your neuroleptic malignant syndrome, you can see increase in creatinine kinase. Why? Myopathy. You have myoglobinuria. Only in your neuroleptic malignant syndrome, you can have that. You can also have lead pipe rigidity. I'm sorry, lead pipe rigidity for your NMS. For serotonin syndrome, they see tapping of the feet. If they said tapping of the feet, that's myoclonus. Okay, that's specifically for serotonin syndrome. What's the treatment for serotonin syndrome? 5-HT3 antagonist. What is that? Cyproheptadine. What's the treatment for neuroleptic malignant syndrome? You can give dantrolene. Same treatment as in malignant hyperthermia. Excellent. Next, withdrawal from ecstasy. So they're very high. Now the drug is wearing off. What can you see? Down side effects, depression and anxiety, fatigue and lethargy, difficulty concentrating, loss of appetite. Remember the bruxism? You can have jaw soreness from grinding of the teeth while high. LSD. It's a hallucinogenic. Think serotonin, 5-HT2A receptors. It causes high-yield synesthesia. Okay, you have the trip, the LSD trip. You feel expanded consciousness. You can sense things beyond usual reality. You can hear the colors, or you can see sounds. You can have depersonalization. You feel disconnected or detached from your body. Another high yield point, visual hallucinations for LSD. It may cause flashbacks. So if you're withdrawing from LSD, you have a return of effects after stopping the drug. It may occur weeks and days, even months later. What's the treatment? Supportive treatment. PCP, angel dust, NMDA receptor antagonist. What is NMDA? Glutamate receptor antagonist. Is glutamate excitatory or inhibitory in the brain? Is the glutamate receptor excitatory or inhibitory in the brain? Excellent. Amber, it is excitatory. What is the major inhibitory neurotransmitter in the brain? GABA. Excellent, Amber. Tolu, it is GABA. Good job. So, in the vignette, they say the patient was brought in. The patient was agitated. He's destroying property. He's shouting on the nurse. It's very, very agitated, violent against the nurse, against the doctor, against the police. Think PCP. Okay, angel dust. They have agitated, violent behavior. You can have autonomic hyperactivity, tachycardia, hypertension, nystagmus. You have altered mental status. They can have psychotic effects, but no hallucinations. Okay, psychosis with hallucinations, visual or auditory. I'm sorry. But basically, think agitated and violent behavior. They keep on hitting the staff. They're very, very aggressive. Think angel dust, PCP. Most common fatality from trauma, right? They may dissociate. This is very sad. They might walk into traffic. They may jump from buildings. What's the treatment? Give them benzos, GABA, calm them down to calm the psychomotor agitation. Or if it's too bad, really bad, you're inpatient, you admit them inpatient, they're in the unit, and they have psychomotor agitation, you can give Haldol, your antipsychotic, your typical antipsychotic. But what do we need to watch out if we give Haldol? What symptoms are we going to need to watch out if we're giving a rapid-acting antipsychotic like Haldol? We need to be excellent, Lexi, extrapyramidal syndrome. Caffeine. Can you imagine? Caffeine is also a substance, right? I think we all have addiction to caffeine in varying levels. Think antagonist of adenosine receptors, right? It leads to release of dopamine and norepinephrine. That's why if you drink coffee, autonomic hyperreactivity, you feel alert, right? And it blocks adenosine in your nephrons. That's why you keep on peeing, diuresis, after drinking coffee. That's it for our review today. Any questions?